Hello, and welcome to More Life for Living, the Preventative Health Podcast. I'm your host, Alexander Galeazzi. Hello, and welcome back to the More Life for Living podcast. I'm your host, Alexander Galeazzi, and joining me again today is the amazing Dr. Candace Westgate, board-certified OB-GYN and expert in all things women's health. How are you, Dr. Westgate?
I'm doing wonderful. Thank you, Alex. How are you today?
I'm doing well. Thanks for asking. So I'm excited to jump in with you here today. We're going to be talking about hormone therapy and the pendulum sort of swinging the other way around the conversation around that lately. And obviously, you're very well versed in the space. So I thought no better person to ask. Let's set the stage here. What is the lay of the land right now with hormone therapy for women? How is it used? How often is it thrown out as a solution? Just set the stage for me a little bit so the audience knows sort of what we're talking about here.
That question really depends on what provider you're seeing.
Okay. So let's take a step back even further then.
Correct.
Okay.
So if you're seeing a menopause certified provider, you're going to get a very inclusive, holistic approach to whether hormone therapy is an appropriate treatment option for you given your perimenopause or menopause symptoms. Now, back up, because that isn't how it was 20 years ago.
Right. That's what we're talking about, right?
Yes.
It's like, apparently this has changed recently. So what was it back then?
So back then, a study came out, the Women's Health Initiative, which actually was a wonderful study. They were looking to see if we gave hormone therapy to a woman that was at elevated risk of cardiovascular disease, would we help to decrease the risk of having a heart attack or a stroke? Okay.
That sounds beneficial.
Right.
Yeah.
And so what women are at elevated risk of cardiovascular disease? Well, older women. So 70% of the women in that study were over the age of 60 when they started hormone therapy for the first time. Okay. So very different than the landscape now of when we're treating or using hormone therapy. We're using it in younger women during that perimenopause and menopause transition. Okay. So the first part of this was that the outcomes of that study were announced to the world with media, and of course they led with all the negative. Increases risk of stroke and heart attack and blood clots and breast cancer. And so overnight, the sales of Premarin, or the kind of estrogen that was used back then, plummeted by over 80%.
Oh, gosh.
Because of that negative news
that's
media.
the narrative they're going with, right?
Correct.
That it's this scary, doomsday type thing. Yeah, okay.
Correct. However, when the dust settled and sub-analysis was done, what we actually saw was that, those women that were on estrogen alone actually had a slight decreased risk of breast cancer. Okay. And that was never advertised. When you look at the nuances of that study, because it was so rich with amazing data, those women that were on estrogen alone actually had a slight decreased risk of breast cancer.
Right.
It was the women that were on the synthetic progestin and the estrogen, they had the slight increased risk of breast cancer, but it wasn't really even statistically significant.
See. Okay.
So the nuances of the study got totally lost in the fear and the associated medical liability with that big news media headline. And so as a result of that, hundreds of thousands of women for a decade were denied treatment that could help them prevent osteoporosis, treat their genitourinary syndrome of menopause. And what that is the changes in the vagina and the bladder that occur with lack of estrogen, frequency, urinary urgency, nighttime urination, recurrent urinary tract infections, significant quality of life issues.
Yeah, things that are pretty significant in how they live day to day.
Correct.
Wow. And so they were just told that this is this scary thing, don't take it, but it could have been helping them all that time.
So decades of women suffering as a result of this. Now, when sub-analysis was done just in the woman within the 10-year window of opportunity is what we now call it. So those women who'd recently gone through menopause or within 10 years of going through menopause, when we looked at the data of those individuals, there wasn't the significant increase of stroke and heart attack and blood clots. So understanding the data helps to pass out personalized treatments for people in perimenopause and menopause.
Right.
And so there isn't a blank statement now, or there shouldn't be at least, that everyone should be on hormone therapy and it's totally safe for everyone. That's not the case. But previously, it was that everyone should not be on hormones because it's not safe for everyone.
It's this big, scary thing. It can increase your risk.
And that's not true either.
Right. But now let's go back to the talk about the pendulum. And I appreciate you laying that out in such detail because that's one thing I wanted to be specific about and make sure we highlighted in, sort of what exactly was that demographic in that data. But so now the pendulum swinging back, does that mean that you're seeing sort of like this overprescription of hormone therapy?
What I'm seeing a lot of patients coming in thinking that that hormone therapy prescription that they want from me is going to be that magic panacea.
Okay, I see.
It is going to solve all of the problems that they've had for the last 5, 7, 10 years.
Yeah.
Okay.
Yep.
And what I want patients to understand, it is a very important puzzle piece in this picture of yours, but it isn't the only one. Lifestyle, stress management, eating well, exercising well, all of those play into the picture. It's not just menopause hormone therapy, but it is a very important part of the whole story. Okay. So, Alex, back to this personalized approach, and that's what I'd encourage our listeners and patients to find that provider that is looking at that you as an individual, taking the time to first assess your risks. What is your breast cancer risk? What is your cardiovascular risk, right?
And then, real quick, does that include things like family history, genetics, things like that,
absolutely.
right? The questions that don't often get asked?
Correct, right.
Okay.
Or they're asked in the patient's medical chart, but no one's ever taken that next step and acted on what that information is, right? If we understand where a patient's risk is, we'll then know if they are the right person, if they're in the right timing, right, within a 10-year window of going through menopause, and giving the right formulation of hormones. So there isn't a one-size-fits-all approach, right, when it comes to hormone therapy.
So that's the other part. Sorry to interrupt, but that's the other part of hormones, too, is that hormones are not just, this is the hormone, take the hormone, right? There's a vastly complicated combination of which hormones to take and at what doses, right?
Correct, and how to take them. So another great learning that came out of that WHI study was that certain formulations of hormones have very different impacts in our body. So oral estrogen goes through the liver to be metabolized, and it increases clotting factors. And so it does increase the risk of blood clots, just like birth control pills do as well. Right? It can raise blood pressure. It can make headaches worse. It can increase the risk of stroke and heart attack. And so applying estrogen or getting it into our body through the skin, where it misses that liver metabolism or first pass, or as a vaginal ring, we're able to provide estrogen to patients a lot safer so that we're not also increasing risk of blood clots, etc. So the formulation of hormones now is also one of the 3 important aspects. And we're using different formulations than they did back then. They were using conjugated equine estrogen as the oral estrogen that was used, and synthetic progestin or medroxyprogesterone acetate. Now, the majority of providers are using micronized prometrium. So this is a body identical, for a lack of better words.
Is that the term, I think, bioidentical? Is that what that means? Or is that different?
That term is prickly.
Oh, okay.
And I can explain that in a few minutes if you want.
Let's go into that next, because I've heard that as being, you want to find the bioidentical, but I know nothing about that. Let's come back to that.
We'll come back to that, yes. So we're using a different kind of progesterone now, and in the observational studies that we have, don't seem to impact the breast in the same manner or increase breast cancer risk like the synthetic progestins do. So we're identifying the right patient. We understand the timing hypothesis of when is a safe window to start a woman on hormone therapy, and we're doing the right formulation of hormones. So a much safer picture for an individual to consider menopause hormone therapy.
Okay, so let's take it back to the prickly question here. So I heard you say body identical, right? And I've heard conversations around, you want to get the bioidentical hormones. What is the difference between those two, and why is this prickly?
Unfortunately, again, this stems back to what happened with the WHI study and the majority of women stopping their hormones, and the immense suffering that occurred from that. A whole realm of pharmaceutical solutions then came out of the demand for women wanting to feel good again, control their hot flashes, et cetera, et cetera. And so it's actually a marketing term called bioidentical.
Is it? Okay, so it's not medically backed.
Right, no.
Oh, interesting.
And the term was for women to feel that it was safer for them to be on these kind of hormones than the hormones that were used in the WHI study.
And that's exactly the context I've seen it used, is women speaking as if, this is like the safe hormone. This is the one that's okay to use. Is find bioidentical.
So there are a few different bioidentical terms, and I'll break them down for us.
Let's go through it.
So the first is compounded bioidentical. So this is really what came out of the ashes of the WHI study, right? Where women would go to a compounding pharmacy and they would make up a personalized dose for them in a bioidentical formulation of the hormone. So it wasn't the conjugated equine estrogen, it was estradiol. So that's the kind of estrogen that our body recognizes. It wasn't the synthetic medroxyprogesterone acetate from the WHI study that was used. It was the bioidentical progesterone.
Got it. Okay.
And these were, compounded into creams, and the patients would have to, put 2 lines or 3 clicks and rub them in. They would have to get their levels and hormones tested, every 3 months, and then they would, adjust the concentration of these hormones as a personalized approach in a bioidentical manner. Well, since then we have bioidentical hormones.
Body identical, bioidentical.
Yeah.
Okay.
So same.
Same. Okay.
Semantics.
Yeah. Yep.
But that are FDA approved.
Okay.
Okay. So a compounding pharmacy does not have to prove or show that the concentration of the medication that they have written on the label is actually true.
Oh, interesting. Okay.
Correct. Now, there are some more reputable compounding pharmacies that do third-party testing. So if you are using a compounding pharmacy, that's really where you need to make sure they're doing third-party testing. But you have to pay for this yourself, cash. Okay. So there is bioidentical, body-identical menopause hormone therapy that is FDA approved. So as a clinician, I know the concentration that I am prescribing to a patient is exactly what is in that patch or in that gel or in that spray or in that vaginal ring.
Okay. And is there a path here that, you would advise women to, try to get a little more educated before they go in and accept a certain prescription on certain, hormone treatments? What are the questions they should be asking to be well educated going into something like this?
Ask if your provider prescribes bioidentical hormones, but ask, are these FDA approved bioidentical hormones, and does my insurance pay for them?
Okay.
Right? And so this would give you a better understanding of the cost to you, because these can be very expensive, but also the level of safety associated with these medications.
So just asking if it's the FDA-approved bioidentical hormones. That seems straightforward enough. Okay. So Dr. Westgate, we've talked briefly before about the different hormonal chapters of a woman's life. Let's break those down once again and tell me how they pertain to women in general.
I like to think of them as the 3 Ps.
Okay.
Puberty, pregnancy, and then perimenopause and postmenopause. Puberty, we don't remember much of it. Our parents remember all of it.
I'm sure, yeah.
The body changes, the moods, emotions, and then the onset of menses for women. Pregnancy, we definitely remember it very well. Some women love being pregnant, others hate it. Quintessential change, body composition changes, right?
Yep.
But then also the mood changes, the pregnancy brain, the brain fog, significant amount of symptoms that occur in pregnancy. And then no one prepares us, Alex, for perimenopause and postmenopause. It's been dismissed for many years. We don't have the same amount of education and information that we provide to our patients and prepare them for this. Think of what we do for a prepubescent girl or boy, getting them ready for. We even have classes at school for this.
Yeah,
right?
a little bit of education available.
Right. For pregnant women, there are birthing classes and hundreds of books to help them understand, and apps to help them understand what's going on in their body, why it's changing. Thankfully, the tide is turning now when it comes to perimenopause and postmenopause. And we're seeing a revolution in regards to women standing up and saying no more. And we need to start talking about this. We need to demand that our moms and our aunts and our grandmothers talk to us about this phase of life and not just dismiss it like they have been dismissed in that cycle of their life. So there's a significant amount of preparation that we can do to get our bodies ready for this, to understand all the changes that occur. And we have to be prepared for the body composition changes that occur in each 3 areas. Now, I say to a lot of my patients, let's go back to pregnancy and tell me what pregnancy was like for you. Did you have significant anxiety or depression? Did you have gestational diabetes or high blood pressure? So the stress event that's pregnancy and the hormone changes that occur in pregnancy can often be a foretelling for us of what we need to look out for and what the hurdles are going to be facing that patient in this next and third hormonal transition of their life, perimenopause and menopause.
Okay.
It's so astounding to me, and I was even shocked when I was like, but so many patients don't connect, and they're fine with their body changes in puberty and in pregnancy, and then they are just devastated by the body changes that occur in peri and postmenopause. But when you put it in the lens of it's all hormonal related,
Right.
it has nothing to do with your self-will. It has nothing to do with exercise more and eat less. Even with that, the hormone changes happen even with you doing absolutely everything right.
It's just another chapter of life, but it gets treated as this like,
Yeah.
oh no.
And it's your fault.
Right, exactly.
Correct.
Yeah, like more condescension, dismiss it. Yeah.
Yes.
I watched my mother go through that. Yeah,
Right.
I know exactly what
Yeah.
you're talking about. Yeah, literally. So going back again, more specifically to the hormones, we touched briefly at the beginning of the episode around how there was this study done years ago, and the information was kind of muddied, I guess you could say, at the end. Have there been new studies done, or where is the science at today?
Alex, this is a difficult question because we will never have that level of evidence, that amount of money put into a randomized controlled trial about menopause hormone therapy in women ever again in our lifetimes.
Why is that?
Well, because that study cost millions of dollars.
Fair enough.
And so that level of research with a double-blind randomized controlled trial, right, which really is the gold standard and the panacea of research.
Sure.
We're not going to get that.
Yeah.
Now, right now, in the way that research works, a lot of it is funded by our pharmaceutical companies because of drug development. And so when there is new breakthroughs, it's usually coming from that kind of medical breakthrough. And there's no money to be made in that side of things. So that aside, what we do have is additional studies, more like observational studies. So not the gold standard of what we would like, right? Just recently, Melinda Gates donated a significant amount, I think it was about $215 million towards women's health research, specifically focused on menopause and midlife
great.
health.
I didn't know that. That's awesome. Okay.
So really exciting to be in this phase of the development and understanding a lot more of what's going on.
Yeah. So there'll be more science to come, too,
Absolutely.
it seems like. Okay.
One thing I did want to bring up was that in the past, it had always been the lowest dose of hormone for the shortest amount of time possible. Don't go over the 5 years. And when you're 60, you got to stop it. That had
So it's very
been
strict.
Correct. That had been the understanding to balance what was previously understood about the risks and benefits of being on menopause hormone therapy.
Okay.
Right. So thankfully, we have menopause hormone guidelines and position statements from the Menopause Society that really helps us to peel apart where the evidence is, where the evidence isn't, what we still need, but what we can do to help patients now with their suffering. And so just because you've been on hormone therapy and now you hit the age of 60 does not mean you have to stop your hormones. What it does mean is that we need to take a breath, reassess your risk. If your cardiovascular risk is still low, if your breast cancer risk is still low, you do not have to stop your hormones just because you turn 60.
Okay.
Okay.
So it's more about making sure you have information to know where your overall risks are at, to know whether you should continue.
Yeah.
Not this is the time to stop.
Correct.
Interesting. Okay.
The other thing that I wanted to make mention is that a lot of physicians have the idea that a woman can only start hormone therapy once she is 12 months after her last menstrual period, so postmenopausal.
Okay.
Okay. What we now know, we think there's an association with starting menopause hormone therapy earlier or in the perimenopausal years actually has significant benefit.
Okay.
We do not have to wait until a woman is 12 months since her last menstrual period to start menopause hormone therapy. She can still be having erratic periods. And supplementing and helping her body with the low lows and the craziness is extremely benefit for bone health, for cardiovascular protection, to help with mood, mind, memory.
Yeah.
So we know that we can move that menopause hormone therapy treatment a lot earlier than waiting until a woman is postmenopausal.
Because that's years earlier,
Correct.
right? I mean, many years earlier from what we talked about earlier, right?
Yeah. And here again is the wonderful nuance.
Okay.
And why a lot of providers don't enjoy this kind of work is because it's difficult to treat a woman who's still having a period every month and giving her more hormones on top of that, right?
I see, okay.
She's still having a period every month. That means her ovaries are still working. She's releasing an egg, but there's underlying hormonal chaos going on still,
sure.
right? So in perimenopause, it's actually a lot more complicated oftentimes to get a woman's symptoms under control and her feeling like herself again compared to a postmenopausal
You have a lot
woman.
more factors in the mix, it
Correct.
sounds like.
So we're dealing with her own ovary working and creating hormone fluctuations. We're trying to help her bring back the balance.
Right.
And we do that with something called ovarian suppression versus just putting menopause hormone therapy on top of her.
Well, so it sounds like it's another reoccurring example of a more personalized approach is going to always be the answer than sort of this, one size fits
Correct.
one and, just cookie cutter blanket statement. Here's your range. Here's where you are. You're fine kind of a treatment. Okay. That makes sense. Another point for personalized care, I suppose.
Absolutely.
Then, right? So speaking of the personalized approach and the preventative medicine narrative, right, we're seeing a lot more conversation around people checking their bone density, their breast health, their cardiovascular assessment, right? So how does all that factor into hormone health as well, right? Because I imagine that makes it even more complex or maybe more accessible. Talk to me a little bit about those things.
Absolutely. So this is really twofold. First, as a woman's body is changing, metabolically it's changing. So there's actually 5 things that we need to start to pay attention to in a midlife woman that we've been able to ignore previously because she's had her protective superhero estrogen. Okay.
All right. This comes back to the
Yes,
estrogen changing.
correct,
Yep.
right.
Yep.
So cardiovascular risk, the number one killer of women, right? So we have to start being proactive, checking cholesterol, doing advanced lipid labs, and that heart scan. That is a very valuable piece of information, picture of those coronary arteries to see if there's any calcium deposits indicative of hard plaque built up, so we can see what's actually going on, not just calculating a risk number for them.
Things like a CCTA or
Correct.
breast arterial calcification, things like that. Yeah.
Correct. So the next one is bone health.
Okay.
When estrogen declines, there is an imbalance between 2 cells within a bone, osteoclasts and osteoblasts.
Okay.
Okay. And that imbalance then, when estrogen goes away, creates declines very fast of bone strength for women.
Okay.
And so currently the guidelines are to get your first bone density scan at age 65.
So that's a little late, isn't it?
Right. So that, on average 15 years after menopause transition
It's like
for
we
a
were
woman.
just talking about even perimenopause is back at sometimes 35-ish. So
Why so long?
yeah.
Well, in the studies, they showed that the lowest that a woman's bone density gets to is about 10 to 15 years after her menopause transition.
Okay.
And so if we check it then we'll be able to find all the women who have osteoporosis.
Okay, that makes sense then.
But that's if we're practicing sick care, Alex.
Right, not preventative.
Correct.
Right.
And so understanding where a late perimenopause, early menopause woman's bone density is so vital for us to be able to offer a personalized approach to prevent her from even getting osteoporosis in the future. And guess what? One of the FDA-approved reasons are for starting a woman on menopause hormone therapy.
What do you got?
Prevention of osteoporosis.
Really?
Yes,
okay.
sir.
So prevention of osteoporosis is actually a reason to prescribe hormone therapy.
Correct.
Okay, well, that's a pretty good, positive consequence of also doing hormone therapy for other reasons too, right? Or
Correct.
vice versa.
Exactly,
Right?
vice versa.
Okay,
Yeah.
interesting.
Yeah. Okay, so we've spoken about
Yep.
cardiovascular disease. We've spoken about bone health.
density.
Yes,
Yep.
and bone
Now
density.
let's talk about breast health.
Yes, we'll get there in a minute.
Oh, we'll get there in a minute. Okay,
brace
what's
is
next?
this one.
Okay,
You got to
okay.
follow my
I'll follow you,
algorithm.
I'll follow you. You're the
Absolutely.
doctor. I'm listening.
The next is genitourinary syndrome of menopause. So a big mouthful, GSM is what we call it. And these are the changes that occur in the bladder and in the vaginal and vulvar tissue of a woman when estrogen goes away. That tissue is extremely estrogen sensitive. And over time, a woman starts to get dryness with sexual intimacy, pain. She can even start to bleed after sexual intimacy. And then the bladder starts to act up, and she can have symptoms of urinary frequency, urgency, nighttime urination, recurrent urinary tract infection, even urinary incontinence that she's never had before. So women think they have overactive bladder syndrome. All that it is we need to get some estrogen within the vagina. So that genitourinary syndrome of menopause causes a significant decline in a woman's quality of life. And as she gets older, significant rise in the amount of hospital administrations for urosepsis.
Okay.
Okay,
Yep.
and that can all be prevented by paying attention to these body changes that start to occur in a woman's 50s and early 60s.
Yeah, another thing that's very easily preventable, it sounds
Right.
like. Yeah.
Yeah, absolutely.
Okay.
The next thing that we need to start paying attention to is neurocognitive health.
Okay.
Okay, why? Well, 1 in 5 women will develop dementia or Alzheimer's in their life. Okay, and 2/3 of Alzheimer's patients are females, not males.
Okay. I didn't know
So,
that. Okay.
yes, so there is a connection between being a female, your brain health, and your hormones.
Yeah. Yep.
Now, this is not a reason to stop menopause hormone therapy. If you're having
Okay.
some brain fog, that alone,
Sure,
right?
sure.
The research that we have right now shows us a neutral effect for starting menopause hormone therapy in regards to preventing Alzheimer's or dementia. So it's not increasing a woman's risk if they're on it, but it's right now we don't have good data to show that it's decreasing a woman's risk.
I see. Okay.
However, if a woman in her 60s is on oral estrogen, then we know there is an increased risk of Alzheimer's and dementia. So here again, Alex, this is such a nuanced discussion
Yeah.
that oftentimes gets overlooked, and just a blanket statement gets put on whether a woman should or shouldn't do hormone therapy.
Right. Right. Because
that make
again, it's
sense?
just easier to throw out the one size fits all kind
Yes.
of thing. Yeah. Okay.
Okay, and then the last one is cancer risk.
Yes.
So just being over the age of 50, there is about a 13-fold increased risk of having any cancer over the age of 50 than if you're
50,
younger than
okay,
the age
wow,
of 50.
okay.
So age alone, unfortunately, is one of the biggest risk factors for developing cancer.
Okay.
From a woman's health perspective, obviously, breast cancer is at the forefront of all of our thoughts. We see it on the football field, right? In the month of October with breast cancer awareness month. We know so much more about breast cancer because of this kind of awareness, because of the amazing amount of monies that has been put into breast cancer research. And breast cancer isn't just one disease, it is multiple diseases with a multiple amount of treatments.
Right.
Okay. We're able to go upstream so much better now when it comes to personalized breast cancer risk assessment. This includes understanding the patient's family history, calculating a lifetime risk of breast cancer. One such tool that can be used is something called the Taracusic risk. And that will give a woman a number. If her risk is above 20%, that's considered the increased risk of breast cancer. And her screening should look very different than a woman who is not at increased risk and general population risk. So elevated risk means we got to watch you closer. We got to change the way that we're screening your breasts as well. And so what it looks like for a woman is a clinical breast exam every 6 months instead of once a year. It means getting a mammogram, 6 months later, a breast MRI. So she's not going for longer than 6 months without some kind of
some
imaging on her
check-in.
breast tissue, because we're so good at picking up breast cancer at an early stage now. And that is the magic of why so many more women survive breast cancer now than they have in the past, is because of our ability to engage with early detection for our patients.
Well, that was even before some of the new AI stuff you see,
Correct.
right? That's increasing
Yes.
the detection to even earlier stages,
earlier,
right?
Then
So-
there's genetic testing that can be done for cancer risk. So it's really important, again, the risk assessment for our patients and looking at our midlife patients through a completely different lens than we do our reproductive patients, because we understand the big metabolic shift and the risk shift that occurs when our superhero goes away.
I certainly am learning a lot about that moment in a woman's life.
Yeah.
Hopefully that's going to be a valuable piece for the listeners out there as well. Okay, so in a previous conversation, I asked you once, what is the right protocol a woman should have when trying to find a trusted provider? I'm going to ask you a similar question this time, which is, what questions should a woman be asking when exploring menopause hormone therapy? How does she educate herself in the right way to find whether or not she's a good candidate, and who should she be listening to?
And there is so much noise out there, Alex.
I'm sure,
so
yeah.
much noise. So many influences, so many books out there now, which is really wonderful because there wasn't anything. And for the longest time, women had to struggle through this time of life, and they were told, everyone goes through it. Here's a happy pill or an antidepressant, and buy a fan. Those were the two options, right, that women had for the longest time. And then the dismissal that came with all of their symptoms that they were experiencing. So what should women do? I highly recommend that a woman starts keeping track of her symptoms, even the weird ones. But keep track of the symptoms that you're having. Keep track of your menstrual periods and how they are changing, so that when you come to your provider, You're going to say, these are my symptoms. This is where my menstrual cycle is. What would be a personalized approach for me? And I think a big question, too, for listeners out there, for those who are not open to hormone therapy, I would encourage you to be open. You still may decide that that's not the right route for you, but most women have never been given an appropriate informed consent discussion about the risks and benefits associated with menopause hormone therapy. So come into your visit with your menopause certified provider with an open mind to explore multiple different options. Well, in our previous episodes, we spoke about the fact that there isn't one magic bullet.
Right. Course.
Right. And hormone therapy is one important part of this puzzle piece, but it isn't the only one. There is a multitude of lifestyle, nutritional deficiencies that can be fixed, right?
Yep.
Iron deficiency that can be fixed. Thyroid problems really increase during this phase of life as well. And so you want a provider who is going to be, number one, listening to you. Number two, offer you resources to educate you with evidence-based information. And number three is going to talk to you about a multitude of options, including lifestyle changes, not just throwing pharmaceuticals at you.
Yeah. Okay. So once again, sounds like someone who's more interested in hearing about your personal needs,
yes,
your personalized
correct,
plan,
and what your
than
goals
just,
are.
Exactly
Yeah.
what the goals are. Then just, again, that range. Here's where you are. Just go forth and do the same thing as everyone else.
Yeah.
Yeah.
Our tool belt now, in regards to taking care of a perimenopause woman or a menopause woman, is so much larger than it was previously. Just in the last few years, we've had 2 new non-hormonal hot flash medications that are FDA approved. They're neurokinin receptor antagonists. They work in the thermoregulatory center in the brain. So for a lot of patients who cannot or have contraindications or reasons why they cannot take menopause hormone therapy, there is an array of treatment options for them as well. So for a lot of my patients who are cancer survivors coming in to see me, my first discussion with them is that you are not missing out. You should not feel less than, because with the pendulum swinging this way, so many women are feeling left out, really disheartened because they maybe can't take hormone therapy now. Maybe they're out of that window of opportunity and they were never offered it previously. Or they have a real contraindication, an estrogen-positive breast cancer. I want those patients to know that we have a significant amount of tools in our tool belt, that we can help you with all of the associated menopause symptoms. And there is ways to keep you healthy and improve your health span even without menopause hormone therapy.
It sounds like we're at a great time, and at least in this journey where women can find the right information for their personalized needs and then go forth and actually start feeling better, which is, huge. At least that's what I'm hearing from you.
Yes.
So,
Women's suffering has gone on for way too long. We're having a moment right now. I'm so grateful to be part of it.
Yes, absolutely.
And we got to do better. We got to provide better access for patients, and we got to start listening to ourselves, to those whispers of what our symptoms are, and find the provider that's going to listen with you.
I don't think I could possibly have a better outro than that, Dr. Westgate. So I'm going to leave us right there for this conversation. So thank you again for joining us. We'll have all the information that Dr. Westgate spoke about linked below in the show notes. Any references will be linked below as well. Please feel free to submit us your questions. We'll read them here together and have more conversations in the future. So thanks for watching.